You know the exact feeling. You walk into the ED for a night shift, you glance up at the tracking board, and it seems like half the rooms are filled with the exact same chief complaint.
Low back pain.
Exactly. Low back pain is just this relentless kind of grinding conveyor belt of emergency medicine, you know?
It really is. And the sheer volume of it creates this immense cognitive load for you. I mean, we all know that, 90 to 95% of these presentations are just non-specific mechanical musculoskeletal pain?
Yeah, the routine stuff.
Yeah, but it's that remaining 5% that represents a terrifying diagnostic minefield, because a missed pathology there leads to, irreversible catastrophic outcomes for the patient.
Not to mention massive litigation for the physician.
Oh, absolutely. It's a huge source of lawsuits.
So today, we're going to recalibrate your clinical radar for that 5%. Welcome to the deep dive. We're integrating a stack of highly clinical sources today.
Some really great stuff in here.
Yeah, we've got the latest NICE guidelines, the official GRFT that's getting it right, first-time national suspected Cauda equina syndrome pathway, and some incredibly nuanced emergency diagnostic research out of Oxford.
The overarching mission here is to build a mental framework so you never miss that one case, the one that could cost a patient their mobility or even their life.
Let's ground this right away with an evolving case. Imagine you're midway through a really chaotic shift. A 45-year-old patient presents with severe, unrelenting low back pain.
Statistically, your brain immediately wants to anchor on a lumbar sprain.
Right.
Or maybe a bulging disc.
Right, because you've seen 10 of those already today. But the sources push us to actively fight that anchoring bias, and they suggest deploying the CRAFTI framework.
Yeah, CRAFTI is incredibly useful. It widens the lens.
Exactly. I'm not going to list every single letter like a textbook. I mean, we all know T is tumor and F is fracture. But the real utility of CRAFTI is that it forces us to evaluate the plumbing and the organs.
Right, not just the lumbosacral scaffolding. You're looking at vascular catastrophes, renal issues, deep infections.
The A and the R are where I think practitioners frequently get burned, honestly.
Oh, for sure. Renal colic, or a retroperitoneal process like pancreatitis, for example, can refer pain entirely to the lower back.
Because of how the visceral afferent nerves enter the spinal cord, right, like around T10 through L1.
Spot on. The wiring is tricky.
But I'll push back a bit on the A, the abdominal aortic aneurysm. I mean, a leaking AAA or an acute aortic syndrome usually looks like a sick patient.
I think so, yeah.
Right. They're hypertensive, they're tachycardic, diaphoretic. They don't typically look like a guy who just pulled a muscle deadlifting in his garage.
Well, that is true when they are actively rupturing. But a contained retroperitoneal leak, or maybe an early expanding dissection, can present purely as severe tearing back pain.
With totally normal vitals.
With completely stable hemodynamics initially. Yeah. The sympathetic nervous system is it's compensating. Wow. So if you cognitively lock onto a slip disc and send them back to the waiting room for a muscle relaxant, they might arrest before you ever see them again. You have to consider those non-spinal causes first.
Okay, that's terrifying, but very good to keep in mind. So let's say we've palpated the abdomen, checked the pulses, and ruled out the plumbing. We are back to the spine.
Right back to the scaffolding.
Our 45-year-old patient mentions, almost offhandedly, that the pain is waking him up at multiple points during the night.
A classic red flag.
Yeah, the literature uses the back pain mnemonic to screen for these, and pain at night is a massive one. But mechanically speaking, why does the time of day matter so much?
It basically comes down to the biomechanics of offloading. Mechanical discogenic pain typically improves when the patient is supine.
Because you're taking gravity out of the equation.
Exactly. You're removing the axial load. So if the patient is lying completely still in bed and the pain is escalating, you're dealing with a totally different pathophysiology.
Like what?
Well, you're likely looking at inflammatory exudate pooling, like from discitis or an epidural abscess, or maybe a malignant metastatic process expanding and stretching the periosteum.
And without the distraction of daytime movement, they really feel it.
Right. It's a hallmark of invasion or inflammation, not mechanics.
Got it. Now, the Oxford paper stresses the absolute necessity of a meticulous physical exam if any of these red flags trip positive.
It's non-negotiable.
But let's be real about the environment we actually operate in. Emergency departments are, well, they're war zones of efficiency.
They are.
Are we really supposed to do a highly detailed S2 to S5 dermatome map and full reflex testing on every single person who tweaks their back lifting a box?
Well, not every single one. But the threshold to escalate to that gold standard exam needs to be way, way lower than current practice dictates.
Okay.
The critical takeaway from the literature is that negative responses to red flag screening questions do not safely rule out pathology.
So you can't just chart denies bowel or bladder incontinence and assume the lumbosacral roots are safe.
You really can't. If there's any hint of radiculopathy or an abnormal screening question, you have to pull out the reflex hammer and the neurotip.
We're doing the full workup.
Yeah, but the exam must be targeted. You're testing sensation across all lumbar and sacral dermatomes. You specifically need to ensure you check S2 through S5.
And motor testing, too, obviously.
Right, test power in the lower limb myotomes and assess the L4 knee jerk and S1 ankle jerk. You are hunting for clues that map the specific symptom to the anatomy.
And that's exactly where the Oxford research warns about missing cervicothoracic compression, right?
Yes, that's a massive pitfall.
Because if I'm examining this patient's legs and I elicit a positive Babinski sign, or I find sustained clonus at the ankle, I've just left the Cauda equina entirely.
Exactly. Those are upper motor neuron signs.
Which means the lesion is above the colon spidularis.
Spot on. The Cauda equina itself is a bundle of peripheral lower motor neurons. So compressing it causes flaccidity, diminished reflexes, fasciculations.
Not brisk reflexes.
Right. If you see brisk reflexes or increased tone, and you only order an MRI of the lumbar spine, it's going to come back pristine.
And you'll completely miss the thoracic mass that's actually compressing the cord.
And that patient might wake up paralyzed.
All right, let's pivot back to our guy. Let's say our patient doesn't have upper motor neuron signs, but his right leg is starting to feel incredibly heavy, and the pain is now shooting down both calves.
Oh, boy.
Yeah, we are walking right up to the edge of the one diagnosis that keeps every ED doctor awake at night. Cauda equina syndrome.
CES. It is the ultimate time-critical spinal emergency. We're dealing with an acute or rapidly progressive compression of the lumbosacral nerve roots.
And it translates to horse's tail.
Yeah, because of how the nerve roots fan out at the base of the spine. While it's rare, we're talking about 1 in 300 ED back pain presentations. The pathophysiology explains exactly why the window for intervention is so incredibly narrow.
Well, the nerve roots below the colonus are incredibly vulnerable from a vascular perspective, right?
They really are. They're supplied by end arteries. They completely lack a robust collateral anastomotic network.
So no backup blood supply.
None. Plus, there's a recognized region of relative hypovascularity just below the cumeus medullaris.
So when a massive central disc protrusion, like typically at L4, L5, or L5S1, compresses that space, it's not just a mechanical block.
No, it rapidly causes venous congestion, which then spikes the local tissue pressure and collapses the arterial supply.
So it's an ischemic cascade. The nerves are essentially suffocating.
Suffocating is the perfect word. The resulting ischemia becomes irreversible very quickly, if not decompressed urgently.
Which is why the GIRFT pathway is so hyper-focused on those specific, subtle autonomic symptoms.
Exactly. We aren't just looking for total incontinence. We're looking for difficulty initiating micturition, impaired sensation of urinary flow, loss of rectal fullness.
And any new sexual dysfunction, right?
Yes, that's often overlooked, but incredibly important to ask about.
Altered perianal sensation is a huge one, too, in the pathway. And it doesn't have to be this massive textbook saddle anesthesia.
No, it could just be the patient noticing they can't quite feel the toilet paper when they wipe. It could be a very small patch.
Right. But you mentioned bilateral sciatica a minute ago. If they just have pain shooting down both legs but zero autonomic symptoms, is that still a red flag for CES?
Bilateral radicular pain is a massive warning sign. Unilateral sciatica usually means a lateral recess stenosis is just clipping one nerve root.
Okay.
But bilateral sciatica, that implies a large, central space-occupying lesion obliterating the entire canal.
So even if the autonomic fibers running down the absolute center haven't failed yet?
They are next in line. It's impending Cauda equina.
Okay, I'm going to stop you right there and push back on how we actually diagnose this in the real world.
Sure, let's get into it.
Because we run into some serious historical dogma here. If I suspect Cauda equina based on those symptoms, and I skip the digital rectal exam, the DRE, I'm going to get crucified in M&M by the older attendant.
Oh, I know. They still consider assessing anal tone the absolute gold standard.
Exactly. Are these new pathways genuinely telling us to abandon the DRE?
They're telling you to abandon it for clinical decision-making. It is a false idol.
A false idol. That's a strong statement.
The latest meta-analyses have completely dismantled the DRE. They show that using reduced anal tone to detect CES has a sensitivity between, get this, 23 and 53%.
Wait, really? That is literally worse than a coin flip.
It is actively dangerous. because the subjective nature of grading internal sphincter tone leads to false reassurance. A doctor feels some tone and thinks, oh, they're fine.
Wow.
The GRFT national pathway is explicit about this. A DRE is not necessary in the ED to decide whether a patient requires an emergency MRI.
So what is the replacement? We obviously don't just ignore the sacral nerves.
You assess the S2 to S5 dermatomes by recording subjective perianal and perineal sensation.
Okay, so just asking them what they feel.
Right, ask them if they can feel your touch or sharp versus dull around the saddle area. Subjective sensation fails long before the deep motor tone of the sphincter completely gives out.
All right, I will happily trade the DRE for subjective sharp dull testing. That saves the patient a very invasive, uncomfortable exam anyway.
Exactly. It's better for everyone.
But let's talk about the other crutch we constantly lean on in the ED. The bladder scan.
Oh, the bladder scan trap.
Right. If the patient has questionable symptoms, we throw the ultrasound on their pelvis. And if the post-void residual, the PVR, is under 200 milliliters, we rule out urinary retention and discharge them.
Relying on a PVR under 200 milliliter to rule out CES is like relying on a faulty check engine light when the engine block is actively melting.
That bad.
It is arguably the most dangerous cognitive trap in all of spinal diagnostics.
Walk me through the mechanics of why that fails, then. Because logically, if the bladder is empty, the parasympathetic nerves from S2 to S4 controlling the detrusor muscle must be firing, right?
Well, you're assuming normal physiological voiding. In a suspected CES patient, the afferent sensory fibers might be ischemic, meaning they don't feel the bladder filling.
But the efferent motor arc hasn't completely failed.
Or, even more commonly, the detrusor muscle might be entirely paralyzed, but the patient utilizes profound abdominal straining, like a massive Valsalva maneuver.
Oh, I see. So they're mechanically forcing urine past the sphincter.
Precisely. They're emptying the bladder using intra-abdominal pressure rather than actual neurological control.
That makes so much sense.
The Oxford research highlights a truly chilling statistic. 60% of patients who required emergency decompressive surgery for confirmed Cauda equina syndrome had a post-void residual under 200 milliliters on presentation.
Wait, 60%?
60%.
That means more than half of the patients who desperately needed their spine opened up would have, quote-unquote, passed the bladder scan test and been sent home.
Yep. A bladder scan is an adjunct, not a rule-out tool. Now, the inverse is true. If the PVR is over 600 milliliters, the likelihood of CES skyrockets.
And you must act immediately.
You have to catheterize them right then and there to prevent a bladder distension injury. If the detrusor muscle is stretched beyond its physiological limit, you are adding a permanent mechanical injury to the ischemic neurological one.
And the sources mention doing a catheter tug when you place it, right? To check for urethral sensation, just documenting whether they can feel the catheter passing.
Yes, that's a very helpful clinical finding.
Let's bring this all back to our 45-year-old patient and apply the GRFT pathway directly to him.
Let's do it.
So, the exam is done, no DRE, subjective perineal sensation is intact, PVR is 150 milliliters, but he does have that sudden onset bilateral radicular leg pain. No autonomic symptoms at all, though. What's the actual disposition?
The GRFT pathway stratifies this beautifully. A patient with sudden bilateral sciatica, but absolutely no CES symptoms, no bladder, bowel, or saddle dysfunction, requires an urgent MSK referral.
So they need to be seen in an outpatient spinal or musculoskeletal clinic within 2 weeks.
Correct. They do not get the 3 a.m. emergency MRI.
Okay, good to know.
But they require ironclad safety netting. You provide warning cards, direct them to the official Physiotherapy Society safety video, and you ensure they understand the exact autonomic symptoms that should bring them sprinting back to the ED.
Got it. Let's change the timeline, though. Same patient, same bilateral sciatica, but he looks at you and says, you know, since yesterday, I haven't been able to feel the toilet paper when I wipe.
Well, that changes the trajectory completely. He now has a recent onset of a new CES symptom. The pathway defines recent onset as 14 days or less.
Okay.
This patient requires an emergency MRI.
And the pathway dictates that has to happen within 4 hours.
Within 4 hours, yes.
Look, if I'm moonlighting in a community shop without 247 MRI capabilities, 4 hours is incredibly tight. I can't just admit him and wait for the morning radiology crew to show up.
You absolutely cannot hold them in a bed. You have to initiate a Category 2 blue light ambulance transfer to the newest tertiary center with emergency MRI provision.
Because time is spine.
Exactly. The longer those end arteries are compressed, the higher the risk of permanent autonomic failure.
Let's play this out. What happens if the scan lights up? A massive L5S1 herniation is just crushing the Cauda equina. The surgeons take him to the OR. What is the actual reality of the prognosis here?
The NCEPO, that's the National Confidential Inquiry into Patient Outcome and Death,
Yeah.
they categorize decompressive surgery for CES between levels 1 and 2.
Meaning?
It is classified as time-sensitive and life-changing, but not life-threatening.
Life-changing because the morbidity is just so high, even with swift intervention.
The post-operative reality is intense. Complication rates for CES decompressive surgery are 6 times higher than for routine spinal surgery.
6 times higher. Wow.
These patients face profound, life-altering deficits. They require a trial without catheter, a TWOC early on to assess detrusor recovery. They need immediate mobilization.
And I imagine the psychological impact is massive.
Crucially, they require significant psychological and sexual health support. We're talking about the potential permanent loss of the most foundational, private bodily functions.
It's a sobering reminder of why our clinical radar really needs to be flawless. Let's synthesize the crucial shifts in practice we've covered today.
Good idea.
First, fight the anchoring bias of mechanical back pain. Deploy the CRAFTI framework early to catch the vascular and renal masqueraders.
Right. Don't miss the AAA.
Second, recognize that negative red flags do not rule out pathology. You must hunt for the upper motor neuron signs that point to a lesion higher up the cord.
Look for the clonus.
Third, the DRE is no longer the gold standard for Cauda equina. Rely on subjective perianal sensation testing instead.
Ditch the DRE.
Fourth, a bladder scan under 200 milliliter provides zero safety guarantee.
Remember the 60% rule.
And finally, follow the GIRFT pathway ruthlessly. New autonomic symptoms within the last 14 days mandate an emergency MRI within 4 hours, even if it requires a blue light transfer.
That covers the operational mechanics perfectly. But there's one final, truly fascinating pathophysiological concept from the Oxford research that we should probably address.
Oh, I know what you're going to say.
It's something to consider the next time you encounter a textbook clinical presentation that completely defies your expectations.
You were talking about scan-negative CES.
I am. Imagine your 45-year-old patient presents with everything we just discussed: urinary retention, profound saddle anesthesia, bilateral leg weakness.
The whole terrifying package.
Exactly. You rush him to the MRI within that 4-hour window, expecting to see a massive central disc obliterating the canal. And the radiologist calls you to say the scan is completely pristine.
No structural compression.
No structural compression, no epidural abscess, nothing.
How often does that actually happen in practice?
It is shockingly common. Up to 85% of patients undergoing an emergency MRI for suspected Cauda equina syndrome will have no identifiable structural cause for their symptoms.
85%. With severe documented autonomic failure, the reflex arc must be breaking down somewhere else then.
The symptoms are entirely real, but the pathology is functional rather than structural.
That's wild.
The prevailing theory challenges our whole understanding of the nervous system's response to extreme pain. The idea is that acute, severe, mechanical pain, like perhaps from an extreme muscular spasm or a chemically irritated nerve root, triggers a massive sympathetic overdrive.
Oh, so the sympathetic nervous system ramps up so high that it functionally inhibits the parasympathetic control of the pelvic floor.
Exactly. It's a functional central and peripheral inhibition. The pain signals are just so intense that they act like a circuit breaker, shutting down the normal detrusor contraction and pelvic sensation.
So the patient experiences genuine urinary retention and saddle numbness out of pure pain-induced inhibition.
Right, not because a disc is physically starving the nerve of blood.
The hardware is perfectly intact, but the software basically crashes because the system is overwhelmed by distress signals.
It highlights the profound complexity of the human nervous system. A pristine MRI doesn't mean the patient was faking. It means their neurophysiology was pushed past its breaking point by pain.
That fundamentally changes how you view the patient sitting on the stretcher. So the next time you walk into the ED and stare at a tracking board full of low back pain, remember the complexity of the pathways we've discussed today.
It's not all just pulled muscles.
No, it's not. The vast majority of it will be noise. But buried in there is the signal of a life-altering emergency. Equip yourself with the right frameworks, abandon the outdated dogma, and trust your clinical radar. Thanks for joining us on this deep dive.